Welcome everybody to today's webinar. Today we're going to talk on the topic of immunisations and living with a compromised immune system for CLL patients. I'm Charlotte, I'm the Patient Advocacy Manager here at Leukemia Care, and I'll be moderating today's session, fielding your questions and things. Just a reminder, if you missed the slide at the beginning, that we don't take questions orally during this session. If you want to ask a question, please use the chat function if you're on Zoom, or if you're with us on Facebook, then just pop it in the comments and a member of the team will send them over to me. So now to introduce my fellow panelists today, maybe Nick, could we start with you?
Yeah, sure. Hi everybody, hi Charlotte. Yeah, today I'm joining you as a patient. Many of you will know me as a patient advocacy and healthcare advocacy officer for Leukemia Care. So I work with Charlotte on a day-to-day basis. But today I'm pleased to be able to join the panel to share perspectives as a CLL patient living with the immune challenges that many of us may do.
Thanks, Nick. It's great to have you. And Gillian, would you like to introduce yourself for me? Sorry.
Yeah, my name's Gillian Marshall. I work at the QE Birmingham and I'm one of the clinical nurse specialists for patients with CLL, and I work with Professor Paul Moss.
Perfect, thank you. And that brings us on to Paul. Would you mind introducing yourself?
Yeah, it's nice to be here. Thank you very much. It's Paul. I'm a consultant hematologist at the Queen Elizabeth with Gillian, and also Professor of Hematology, as Gillian says.
Perfect, thank you. And our first session is going to be a bit of a presentation from you, Paul. So I think I'll hand over to you without further ado.
Great, thank you very much. So I will share the screen. Thank you everybody for coming to join us today. It's always a pleasure and an honor to talk. Yeah, I've got some slides talking about immunity and infection in CLL, and a couple of slides rather idealized, I think, of our environment. That's the university, and there's where Gillian's sitting right now in a rather nice hospital in the center of the country. So what I want to talk about is why patients with CLL are immune suppressed. We'll talk a little bit about SARS-CoV-2 because that is important, but also other infections. And, SARS-CoV-2 remains a huge challenge, but other infections as well are very important. And I will talk about those today. Now, infection is a huge problem in our society still. It's data from a few years ago, it's certainly pre-COVID. 11% of all bed days in hospital are because of infection. Very interesting, isn't it? So it's very fascinating, our relationship with other organisms. We need bacteria to survive. You know that we're made up of, I don't know, 100 trillion cells, but as well as all those, you've got 100 trillion bacteria in your gut, and we need those, right? So we're an ecosystem living together. But all these bacteria, viruses, parasites, and fungi are also trying to survive, and they will use our resources wherever they possibly can. There isn't any sort of evolutionary morality here. And so we've had to evolve a very strong immune system to protect ourselves. And we need that absolutely as a species. But infection can often win the day. And patients with CLL are immune suppressed. We know that. And it's a major cause of morbidity and mortality. Now, the mechanisms remain to be resolved. But, we tend to forget, or some people, I don't think the CLL community, we know this, but, unlike other causes of cancer, breast cancer and so forth, they're not particularly associated with profound immune suppression. But there's something about this type of tumor, the CLL, that makes the immune system weakened. And why is that? We don't know exactly why, but there are certainly two major reasons. One is the antibody levels in our blood go down. We call it this long word, hypogammaglobulinemia. It's a lovely word to say. So antibody levels go down over time, and also our immune cells deteriorate in CLL. Let me just show you an example. This is something I wrote with Francesco a few years ago, but this is antibody levels. This is IgM. This is one of our immunoglobulins in the blood, and there's healthy donors. And these were patients with very early monoclonal B-cell lymphocytosis and then CLL. You can see how they drop off. And as the disease progresses, they drop off very more. So the level of immunoglobulin in the blood decreases during CLL. We've looked at this in our vaccine cohort, the CLL-VR, which you heard about from Helen Parry a couple of weeks ago, and I'll talk about it later. But again, this is the IgM. It's one of the immunoglobulin levels. And this is people who've never had treatment for CLL. Look at the time scale we're studying here. This is 10 years, 20 years. And there is a slight decrease in these antibodies. The trend is down for these antibodies over time. So when we watch and wait, and many of you will be on watch and wait, we are watching the immune system deteriorate to some extent. Not dramatically before treatment starts, but to some extent. Now, why is this? Well, it's possible that these CLL cells that patients with CLL have in their blood, and particularly in their bone marrow, can kill off the good B cells, the healthy B cells, through mechanisms that we're trying to understand. So that's why, because these antibodies that I'm talking about are coming from, not from the CLL cells, but from the residual healthy B cells. So the CLL may be killing them off. The second reason for immune suppression in CLL is disruption in the immune cells, not just the antibodies, but the T cells and the neutrophils. Again, if we look at this thing called the CD4/8 ratio, it's about the T cells, the white cells. We don't need to go into the details, but this is the normal level and this is the early stage. But as you get into CLL and more advanced disease, this drops. So we know that the cellular immune response is also weak. And the final point, and this is an important slide, because it tends to be underestimated. I think it's underestimated by my clinical colleagues, to be honest. That the tumor itself, the B-cell clone, is immune suppressive. This is a complex slide, and I think if we redrew it 6 years later, we'd make it simpler. But I'm going to start here. Just focus on this blue cell. This is the CLL tumor cell. Now, you probably know that there are all sorts of B cells in your blood, but the CLL B cell is a very special subtype. Why is it becoming the one that can become a leukemia so often? Well, one reason seems to be that it secretes immune suppressive molecules. So it's actually dampening down the immune system. It's not a benign bystander. As it develops and expands, it weakens the immune system by what it is making. And that makes total sense. Why does it make sense? Because your immune system is trying to fight cancers and tumors all the time. And this tumor cell, the CLL, can probably only develop because from the start, it was suppressing the good immune response. That's one of its key features. It had to do that. It's a very important point, which I'll come back to. So when we see any patient now with CLL, what are the sort of things that we need to say to them? So patients must be informed of this increased clinical risk at the diagnosis. So when I do see patients and talk about the diagnosis, we will talk about relative immune suppression. And then patients, I either see them with Gillian, our clinical nurse specialist, or she'll see them. But she will also reinforce this. We will optimize vaccination status, and we will talk about that today. And we must also give information on who to contact if they have an infection problem. Now, what sort of spectrum of infectious complications do we see with this disease? Well, early on in the treatment course, it's mainly bacterial infections, urinary infections, chest infections, maybe skin infections. This is similar actually to children and young adults who've had an inherited form of low antibody levels. So when you don't have many antibodies, these are the sorts of diseases that you'll see. And when we think about bacterial infections, of course, these are the ones that for which antibiotics can work. But there are some vaccinations. I will talk later about how we optimize vaccination against some of these bacteria. Early treatment. We tell patients, don't stay at home if you're feverish, febrile, shaking. Seek early clinical care. And then in some patients, this is not something that Gillian and I do typically, but for some of the most vulnerable patients, they might want to have antibiotics at home to start if they are feverish and unwell. And this is typically what we have been doing in the past with patients who have their spleen out, for instance, with that level of immune suppression. Another type of infection that's important, of course, is viruses. And we'll come to SARS, COVID in a minute, but this tends to be pre-COVID days. This was more often seen as a clinical problem in patients on treatment. And these herpes viruses, which are chronic infections, we've all got a bunch of herpes viruses that we can never get rid of. You get them when you're a child and you carry them for the rest of your life. And shingles, I'll talk about it later, can be a real problem in patients with CLL. And also herpes simplex, which is cold sores and so forth. I just want to talk specifically about a couple of infectious challenges because they tend to get a little bit overlooked before we go on to talk about COVID. And this is pneumocystis and hepatitis. And I think they're probably are relevant to many of you because pneumocystis, which is, it's a rather beautiful picture, isn't it, of these. It's now considered as a parasite in terms of its nature. It's a rare subtype of pneumonia, and it's really only seen in patients with really quite profound immune suppression. And many patients who are on BTKIs, such as ibrutinib and acalabrutinib, take Septrin, cotrimoxazole, 3 times a week. And this is what you're trying to stop with that. To be honest, I think the risk of this is very, very small because many of the patients who went on to ibrutinib in the very early days were very heavily pre-treated. And so the few cases there were, I think, were probably related to prior disease rather than BTKI, but that's why many of you may be on Septrin. By the way, Septrin is incredibly effective at stopping this infection. So once you take it, you're fine. The second thing that we often screen for in treatment and planning treatment is hepatitis B. Again, a rather beautiful slide of the virus here. And hepatitis B, you see, many patients harbor, not many patients, but many people harbor low levels of hepatitis, which their body is just about able to control. But when you use anti-CD20 antibodies like rituximab, or obinutuzumab, or chemotherapy, because that weakens the immune system, may reactivate these hepatitis viruses and cause inflammation of the liver. And that's why all patients with CLL who are receiving these therapies should be screened for previous hepatitis infection. And so Gillian and I, when we're preparing somebody for treatment, we'll always do a hepatitis screen. And if there's low level of viral antigen in the blood, you need to give some prophylaxis tablets. And the model is that when you give, this hepatitis develops quite late in therapy, so it can be sort of forgotten about. So when you have cycles of treatment, let's say this is FCR or BR, and you're having this every month, and this weakens your immune system. And over time, the hepatitis virus can gradually accumulate until the end it causes clinical hepatitis. And we want to stop that because that's bad and that's serious. This was a patient who developed hepatitis after chemotherapy. And I think these, by the way, were the rounds of chemotherapy. You can see what that did to the patient's nail bed, which we sometimes see in patients. But we've got great treatments for this as well. And this lamivudine tablet, look, number of reactivation, people on no treatment, 7. People on prophylaxis, 0. So here we are. Here's a couple of examples: pneumocystis, hepatitis. Well, we've got great therapies. We've got great prophylaxis. And so, one of the messages, I think, is that we are improving our infection control in this disorder of CLL, and we're going to get better, and we will promise, and we will get further improvements over time. Now, I've got to say a little bit about SARS because it's so important. Helen Parry talked about this a couple of weeks ago. Helen's clinical fellow and consultant with me in Birmingham, and a great speaker. And I think she's also made a video which you can watch. I'll try not to spend too long, but there are some points I want to just emphasize. We know that it's a big problem. We've got lots of vaccines, and we're trying to optimize these. This is the protein that's in the vaccines. We've all had these vaccines, and the vaccines make this protein. It's the spike from the virus. I show it's just because it's such a beautiful protein structure, as you can see. And this is the sticky virus protein that gets the virus in. But of course, in a vaccine, there isn't any virus. There's just this protein. And what you need to do to respond to a vaccine is to make antibodies against this sticky portion, this purple bit. That's what your immune system must block. And so when we assess how well vaccines are working against COVID, we can either look at the clinical response, how well do they work in patients with CLL, or we can measure the immune system. Let's look at both of those. In terms of how well the vaccines work, they're pretty good in immune suppressed patients as far as we can see. So Public Health England did look at over 1 million people in an at-risk group, and they were about 74% protective at that time point. But, at-risk groups, very, very variable. You can see within that 1.2 million, there's a very small subgroup of patients with CLL. And there was some confoundings because people were shielding at the moment. But, there is a lot of protection clinically with these vaccines, even in immune suppressed patients. However, if you look at people who are getting breakthrough infections, particularly in hospital, some of those are the most severely immune suppressed individuals. That's no surprise, and that's the challenge that we have. What about the immune response? So what we need to assess here is how well patients with CLL respond to these vaccines. And this is, Helen talked about the study that we're running here in Birmingham, the CLL-VR study. It's 500 people. We think it's the biggest leukemia immune vaccine study ever, actually. And we took 500 samples, either through a finger prick blood test or a laboratory test, at the second vaccine. There's your first vaccine, there's your second vaccine, second vaccine, and we took a sample. We also took some 4 months later in a subgroup of patients. So we can look at the peak response and we can see how well the antibodies last. And we're just trying to write this paper up now. We've submitted it to a journal. What's the big picture? As you heard 2 weeks ago, within healthy controls, 100% of people make antibodies to this vaccine. What's the number within patients with CLL? I should be into my teaching role like I do to students and ask you the question, because you had this 2 weeks ago, many of you. It's 67%. So we've got a third of patients not making antibodies. Even when those antibodies are made, there's still only 27% of those in healthy donors. So we have a problem. We have reduced antibody rates and we have lower levels of antibodies. The type of vaccine doesn't seem to matter. There's your mRNA Pfizer, 66%, and there's your AstraZeneca, 66%, and the levels are the same. That is reassuring. Now, how do the antibody response rates vary across the disease course? And Helen will have shown you this, but I think it reinforces some of the bigger pictures that I've told you about immune suppression in this disease. Because if you look at people who are on watch and wait, it's around 80% antibody response. But if people do have quite a bit of disease progression, and they're waiting to be treated. These are the patients saying, I'm just about to start treatment. You can see that the antibody response drops. Now, that's a shame, because obviously you'd want to vaccinate people just before they start treatment. But the problem we have here is that the CLL tumor, which needs treating, is itself immune suppressive. I've told you that earlier. So I think that that reflects the disease burden of the CLL. So we probably need to vaccinate them earlier in the disease course, which of course we are. You will know that patients on treatment make lower responses, and that's true of all the therapies. And we've talked about that before. There are 5 factors emerging as negative risk factors for antibody response. So if we took all these 500 patients and said, who's most likely not to make antibodies? This is what they are. This was a surprise. Men. Men seem to have lower antibody responses. People on BTKIs, ibrutinib and so forth, no surprise. People who are on prophylactic antibiotics because of recurrent infections, no real surprise, because their immune system is weaker. People with low levels of IgA and low levels of IgM, no surprise in many ways, lower antibody levels in their blood. Now, what was interesting, and Helen will have talked about this, was the timing. And I'm not really going to talk about the BTKIs, but I will talk about rituximab and obinutuzumab. And of course, those treatments knock down your antibody response. But if you wait 12 months, it bounces back. So that we've got some evidence that that can recover, and it may need a 12-month time wait. Now, over the, sorry, it's jumping around. Over the 4 months, when we followed up these patients over time, we did see that the antibody levels dropped from their peak. But to me, this is not a problem. And that's probably typical of what you'd see in a control group. Of course, when you vaccinate, you see a peak, and then it will drop slightly. This was reassuring in some ways. And then, of course, we wanted to know how well the blood from these patients can kill the virus. So we sent these blood samples to Glasgow, where they grow the SARS virus in a high containment lab. And we put the blood samples from the CLL patients onto that virus. How did they kill the virus? This was healthy donors. This was the original Wuhan virus. This was Delta. That's the only thing that's around at the moment. You can see within healthy people, the Delta drops a bit. Delta slightly resists the immune system. But in the CLL patients, you can see, wow, unfortunately, it's dropped, particularly against the Delta. So these antibody levels are low, and they are less protective against Delta. So we need to do something about this. So how can we support immune protection? And you will know that there are 2 major ways that we're thinking. One is by the 3rd vaccine. It's one of the big questions at the moment. The other one is an injection of antibodies. Let's just look into that a little bit more. Let's start with the 3rd vaccine. When we did this CLL-VR study and we looked between the 1st vaccine and the 2nd vaccine, the antibody level rose. Just look at these black lines, ignore the red, the black, they really did work. You need two doses of vaccine. They increased the antibody levels by nearly 300 times. And that's encouraging, because if we give you a 3rd vaccine, then maybe this line will continue. So some evidence that that might help. The data so far, there was this nice study from America where they gave 49 people who'd got B-cell malignancy a 3rd vaccine. Only 25 have got CLL, but of those, 38 had no antibody response after the 2nd, whereas some had low. And of the 38, I just want to focus on the 38 with no antibody response after 2 vaccines. What did the 3rd do? Roughly 50-50. Half the patients remained negative and half developed some antibodies. Maybe that's what we're seeing. And Helen will probably have said that she's running the CLL cohort of the OctaDuo here in Birmingham. It's recruited, I think, up to 70 patients in our trust now. And so we will know that outcome soon. And you will know that the Joint Committee on Vaccines and Immunization has recommended a third primary. Why have I put primary in italics? Because this is not your booster. This is your third primary vaccine. And we know that this has been a little bit of a complex story. And in hospitals, we're trying to get our head around it. And Gillian and I can talk to you about what we've been doing locally. But this includes, of course, CLL patients. And then you will get a booster probably at some 6 months down the line. And these are all typically mRNA vaccines. Now, as well as vaccines, there is a group of patients probably who will never respond well to the vaccine. What can we do? Well, what we can potentially do in the future is inject an antibody, a pre-made antibody made in the laboratory. These are called prophylactic antibodies. And we've noticed some patients who've had breakthrough infections. These are CLL patients. Some of them have had virus after the vaccines, have made no antibodies. These are the people we believe to be at risk. Now, the current situation is that we can give monoclonals for people in hospital who come in. And we had a patient last week who came in with CLL, had vaccine, got an infection, SARS, was admitted, and did not make antibodies. So what we can do is give this antibody called Regeneron, because you can see that that reduces the risk of severe disease. That's great, but what we want is to give it in the community to patients out there at home who haven't got antibodies. And what this is looking encouraging, AstraZeneca have made this antibody called AZD7442. Many of you will know about it. And they've published their PROVENT study, and they have applied in America for permission to use this. It looks really good. It's an intramuscular injection. So just finishing on COVID, we don't know all the answers. The data is emerging. I'm sorry for the spelling there, but antibody testing is variable. And of course, we don't measure cellular immunity, but our data from our lab here is showing that the cellular immunity is encouraging. But I just want to spend the last few minutes talking about other vaccinations and other infections. I'll talk about Streptococcus pneumoniae. Of course, you must get your annual vaccination against flu. That's a Cll vaccine, and I'm sure all of you do get that. You know that you mustn't get live vaccines, such as some types of polio, because of the immune suppression. And vaccines should be, if possible, given around treatment rather than during treatment. Pneumococcal pneumonia, bacteria, again, rather beautiful picture of this bacteria. This is an infection, pneumococcus, that's seen at the extremes of age, children under 4 and old people. You can see it increases particularly after 65. And of course, our CLL patients are typically in this older age group, and it can be a serious infection, this can be, particularly with meningitis and septicemia, very high fatality rates. So we need to vaccinate. Patients with CLL should get this vaccine, Prevnar, first, whereas most UK older people get the Pneumovax. And so the evidence is Prevnar, then Pneumovax. But you'd be surprised, I think, and I'd be interested to talk to you all afterwards, at how few people with CLL probably get this vaccine regimen. It isn't really been optimized. So here's the BCSH guidelines, British Society for Haematology. All patients with CLL should be offered pneumococcal vaccination with Prevnar, followed by Pneumovax at least 2 months later. And assessment of response is indicated in those with deficiency. Shingles, nasty infection. Shingrix, this wonderful new vaccine. It's a Cll vaccine. So here's the advice from Public Health England. Look at the date, August 2021. How timely is this? This vaccine, 2 doses for individuals between 70 and 80. And from the 1st of September, only 6 or 7 weeks now, GPs should be offering this to all those who are eligible for shingle vaccines, which is those between 70 and 80, but are contraindicated to the live vaccine, and that is you. So between 70 and 80, CLL patients should be getting Shingrix. The other thing is intravenous immunoglobulin, and some patients will be on injections of immunoglobulin, and this is what the BCSIH guidelines suggested, that people with low antibodies and recurrent infections, you're going to have both, and you failed 3 months of antibiotics, should be offered immunoglobulin. Some considerations, that the amount of therapy here is short supply. It's also expensive. So we found in our CLL VR study, just over, probably about 8 to 9% of patients were on this treatment, about 8%. So consider stopping it if it doesn't improve in the first year, particularly in the summer when there are not so many infections, and continue on antibiotics if you need them. So I think this afternoon, mainly it's for questions and answers rather than me lecturing, but CLL is an immune suppressive condition. We've known that for a long time. We're beginning to understand some of the mechanisms. Optimizing immune control remains a challenge for COVID and beyond, but we're getting better, not as good or as quickly as we want or should, but we're on it. This is a challenging time, but much progress is being made. So I just want to mention some names here. The CLL VR study, really led by Helen here. Graham is another hematology fellow, and Rachel is our manager. They've been sensational in the last year on running this study, which was funded by the government through National Core Studies Immunology, which I run on behalf of Patrick Vallance, and all the patients and the charities, of course, yourself, Nick, and beyond, the Leukemia Care, blood cancer, so forth. I think in the UK, we've made a good contribution. And I think I will stop there, if I may. But perhaps if I could ask Gillian, is there anything I've missed there that you want to say from Birmingham side?
No, I mean, I think just to touch on the, the risk of infections, you've mentioned the low antibodies and the low neutrophils, which are obviously very important, but just on a basic level, just so that people can recognise just the common signs of infection. And I apologise if you already all know this, but obviously if you have a temperature of 38 or more, or if you've got any aching muscles, diarrhea, or you feel excessive fatigue, this can be a sign of infection coming on, and you must contact your CNS team from whatever hospital you're under. So I know that's quite basic, but I just wanted to make sure that everybody was aware of that, to be aware of that if they feel that they're getting an infection. Is that okay?
Yeah, that was perfect. Thank you, Gillian. I think that's a really important point, is to remind everyone, because we all feel a bit under the weather sometimes. So it's useful to remember what we're looking out for, definitely. Thank you both. That was a really great sort of introduction to the topic. We've definitely got two sides again to this, a lot of COVID questions, a lot of non-COVID questions. I wonder if we cover some of the COVID points first. I can always direct people to our previous webinar with Helen where it's covered there, and then I think we'll go on to sort of everything else, if you like. I think this is something that still confuses everyone. Despite mine and Helen's efforts in the last webinar. Paul, I wondered if you could just explain the difference in the purpose between the primary vaccine and the booster vaccine. I think everybody is now aware there are two different types, but they're not quite clear sometimes on the purpose and the reason why there's a distinction between the two. If you could go over that for me, that would be perfect.
Yeah. I think it's a nomenclature. So I think what's being said here is that the standard CLL, the standard COVID vaccine course for the general population is 2 vaccines, and then you can boost it. But I think we're now into a situation where the standard COVID vaccine course for patients with immune suppression is 3 vaccines, and then you can boost it. So I think that's how we have to think about it. And this 3rd vaccine is basically part of your primary course, your first course. And that's why when I was showing the antibody levels increasing between 1 and 2, there is hope that a third one is going to get more people right up to what we believe to be a protective level.
Whereas the booster is to maintain that level once you're
Absolutely.
there.
That's absolutely so, yeah.
Great. I think that's probably more succinctly than I managed in the last webinar, so thank you. That was really helpful. Let's have a look at all the rest of the COVID questions very quickly. I think a few people are still asking around whether they should find out, whether it's possible to find out whether how they've reacted to the responded, sorry, not reacted, to the vaccine, whether they should be asking for antibody tests and things like that. My understanding is it's still not routine to test everybody for a response to the vaccine on the NHS, but I mean, is it useful to have that information as a patient, Paul?
Yeah, I think yes, I totally understand the question. I mean, none of you on the line, and I think there's 83 of us now, if I said, look, we don't know what an antibody level really means for you, I can't give a definitive understanding. I think we all know that's true. However, I do understand that there is a sort of level of interest and confidence that comes with seeing your response. I mean, I think if I was in that position, I'd be very interested to know. So I totally understand it. When patients come to our clinic, we are often measuring antibody levels, and the NHS is doing it, and we'll feed those results back to people when they're coming to clinic. So yeah, and most people are interested either way. And I hope that most trusts are doing that, to be honest. I don't think they're mandated to, but it's a good thing to do. Yes, I can't say to a patient, you are protected or you are highly at risk, but I can see that there's a level of confidence and interest that comes with that. Somebody did ask about cellular immunity, and I am probably the thing I've done more in my science career than anything the last 30 years is cellular immunity. And so we are measuring how the white cells, the T cells, fight the virus. And we're seeing pretty encouraging data from these vaccines, even in patients with CLL. And so when we looked at those patients who had the breakthrough infections, I just showed you their antibody levels were very low. But most of those patients, of the 4 of them were at home and they controlled the disease well. Their cellular immunity was good. And I just mentioned that because antibodies are only part of how these vaccines clinically protect you. So yeah, that's a roundabout and long-winded answer to the question, but yeah, we're increasingly measuring antibody levels to help people. Yeah.
And is this something that you routinely do after other vaccines? So I think people are focusing a lot on getting their response to COVID vaccine in particular, but is this something you routinely do anyway to other vaccines for CLL patients?
It's variable, and it hasn't really been done enough. So people in COVID are trying to develop what they call a correlate protection, i.e., you do the antibody test and you're over 100, and that means, you're 99% protected or more. That's what we want to get to. We're not there yet, but that has happened in other infections. So Gillian and I, for instance, as healthcare workers, vaccinated against hepatitis B, which I talked about earlier, and they measure the antibody responses there. And if they're not high enough, they'll give you another one. So they test how well you respond, and they're pushing that antibody level up. And even for pneumovax and so forth, and I talked about that as well. I mean, the immunologists know the sort of level that is protective, and they'll say what the WHO level of antibody is. And so they'll try and get you above that as well. So it's a reasonable thing to aim for in COVID as well. So yes, we should be doing more of it.
I was on mute, sorry. Gillian, is there anything you wanted to add on how you are talking to patients at the moment about antibody testing and the fact that we're not quite sure about what the antibody test means for COVID when we are sometimes more sure about what it means for other vaccines? Is that a difficult conversation to have at the moment?
We get a lot of phone calls asking for antibody testing, and we're not doing it per se, but if it is a specific reason or a need for it, or it's consultant led, then we will do it. We don't really know how effective these antibody results are, because as far as I know, you can have a lot of antibodies, but they're not all necessarily good ones. So I'm not really sure how effective the results are. Maybe Paul might know a bit more about that. But I think it is something that people are definitely asking for, but unfortunately, realistically, to do it for every single patient would be such a massive cost involved in that, to be honest with you. So we're just trying to do it in specific situations, or if it's consultant led at the moment.
I think that's a good, clever point Gillian makes there. I mean, not all these antibodies are good or useful, and that relates a little bit to what I was showing about the neutralization of the Delta variant when we put this blood onto the Glasgow virus. And what we found is that in CLL, patients with CLL, even when there are antibodies, they're not quite as good at killing off the Delta virus. So just measuring the level doesn't tell you the quality.
Great. Hopefully that's helpful. Nick, I wondered if I could come to you and just, as someone who is, you know, because of your job, is fairly well informed about these things, that you know your antibody results from COVID vaccination. How are you interpreting those results in a measured way? How are you using those, if you're using them?
I have to correct you there. I don't have them yet.
Oh, you haven't.
But I did enter the duo trial that Paul mentioned there, so I should get some feedback. I kind of have an idea where they're going to sit. So if I'm perfectly honest, having had CLL for a long time, I've over time and understanding the level of infections and where I might have weaknesses has told me where I kind of sit in the risk area. I know what infections I'm prone to, and I've been through different aspects of treatment through chemo. I remember, you know, that aspect, and now I live with a compromised immunity. So I'm on immunoglobulin supplements. I'm on a BTK. So from that point of view, knowing my antibodies will probably make very little difference to me, if I'm really honest. I think if I was somebody that was, if I was earlier on in my journey and I hadn't had time to learn my, you know, if I was getting infections or if I was getting inflammatory reactions and things of that nature, then I would be really wanting to know my antibody level. But I'll be perfectly honest with you, Charlotte, and I don't know if that's the right thing to say, Paul, I'm not particularly interested in my antibody response because I don't really think it will change my behavior. I think that also stems back to very early on in my diagnosis, some 10 years ago, we used to have these discussions. Who is immune compromised? How do we actually measure our immune competence? Yeah, we can't. Time. What I've learned is the severity of infections when caught earlier on in the pathway are not normally that severe, and that's not always the case. So very early on, we were all encouraged when we first spoke to our first charities, and to be honest, in the clinical community, talking to doctors at that time, immunity issues weren't really brought up. It was the charities that raised it, and we were all encouraged to take on board some strategies of hygiene strategies and avoidance. We almost had a one bucket fits all, and I've kind of lived with that. The hard thing in the very beginning at that stage in the journey was to try and balance that so that you didn't overreact to every time you got near to somebody with infection, because you might have a strong immunity but you didn't know it. Yeah. So I don't know, it's a difficult one to ask, Charlotte. I mean, I'm fortunate that my employers give me a flexible working arrangement anyway. And it was actually before COVID, as you know, that I had to move out of the office because the number of infections I was getting from staff in the office. So I had a flexible working arrangement and worked from home. I guess, to be honest, the level of infection, COVID infection in the community at the moment is that high, knowing that vaccines don't prevent it and it's still transmissible, and knowing that I'm potentially, because I've known more about my own CLL and the level of infections that I do get, that just causes me to be more vigilant when I exercise those hygiene and avoidance strategies. Does that answer your question? It's a difficult one, Paul, because I don't think it would make any difference to me. Yeah,
I think that's right. That's right, Nick. Yeah.
No, thank you, Nick. I think that's really helpful to put this test into perspective. I think was what I was looking for from you, and I think you've done that really nicely.
But I would like to answer. I would like to answer more, because I know somebody has raised that question, so several people have. the most frustrating thing is that one bucket fits all diagnosis anyway with CLL and your journey of knowing what type of CLL you have, risk levels and everything else, but also the immunity question. Nobody knows what their immunity competence is. Apparently, talking to my clinical friends and colleagues that I work with in Liaison, that patients are tested routinely for immune competence. I'm not sure if that's the case, but patients don't know what their immune competence is. And I think that is a real issue that several people have asked, because that will actually help people employ the strategies that are appropriate for them. You know, I mean, we learn that time is the greatest prognosticator for finding out your time of CLL. It's probably one of the best prognosticators for finding out your propensity to infection. But it is a bit hard for everybody to manage. And that's a big question that several have asked. You know, if obviously COVID-wise antibody results aren't indicative of how much protection you get and how you'll fare in face of an infection, you know, it's just very difficult.
Yeah, I guess that comes back to it links nicely to you, Gillian. I guess you were saying people were phoning you up asking for antibody tests, and even if you can give them one, you have to sort of put a caveat on it that it doesn't maybe not mean an awful lot. How do you then support them to still live with the uncertainty? It hasn't actually told them anything that's useful.
Yeah, I think you just have to, I mean, everybody's so sort of scared and panicky post-COVID, and I think people just want that reassurance that they're protected against the vaccine and that's going to be okay. But I just think you have to be very honest with people and say, yes, we can do the test, but as explained, it might not really be the exact science answer that you want. But obviously when they come to clinic on a regular basis, they know they're being monitored, they know they're being looked after, and really that's all you can do, is just offer that sort of comfort support, really, because we're still learning as well. Yes, we're health professionals, but we've not been through a pandemic before. So what is happening post-pandemic, yes, it's very frustrating for patients, but we are learning as well to some extent as we go along, and we're just trying to support them. And if we can help them by doing an antibody test, if that's going to make them feel reassured, then at least they'll have some picture of what that result is, even if it's not the full picture, and hopefully that will help them.
Yeah, great. I think many of the other questions we have answered in the previous webinar, but I will try and quickly answer some of them that I feel between us we know the answer to. So somebody has asked if they develop COVID, how do they get access to the monoclonal antibodies, and is it only for the hospitalized? I think from your presentation, Paul, the answer is yes, it's only for those who end up hospitalized. Is that correct?
Yes, at the moment, yes. And it's about, well, overall in the whole hospital population, it's been typically around 20% of people who don't make antibodies. I think in our community, it's going to be higher. So it's slightly convoluted, because the patient gets admitted and then they have to have the antibody test, and then it has to come back, and then doctors have to notice that there is a little bit of a delay sometimes in that process. But you can see why they're doing that, because if you do the antibodies to everybody, they're not proven to work. So yeah, I would advocate, if you were unfortunate enough to be a CLL patient, to be admitted to hospital, that you do push for that to be done quickly and acted on.
Great, thank you. One of the things we did cover in the last webinar, but maybe we should touch on again, is should there be a gap between usual jabs like the flu one that you mentioned and the COVID jab? I think we said it doesn't really matter in the last webinar. Would you agree with that, Paul?
I think I would agree with that. I know that people are coming out with both arms sore, aren't they? Flu in one and COVID in the other. I think that's okay. Yeah, there's no evidence. It has been tested for its immunogenicity and was not found to be any worse, so that's fine.
Great, thank you. And then there's a couple of ones that I've not actually seen before that I think might be useful to touch on. Somebody's asked if their usual blood tests for their CLL are likely to be affected after a COVID jab, which I think, Gillian, you responded to with saying there may be a change in your platelet levels. So did you want to, either of you, like to expand on that at all?
That's just something that we've seen, not necessarily through the CLL patient specifically, but generally across the board. If somebody's had a vaccine, we have on some occasions seen a slight decrease in platelet count. I don't know what you feel about that, Paul.
Yeah, I mean, I think there may be some short-term effects. I mean, you know, they can be quite inflammatory, these vaccines. I remember one patient came in, had, you know, quite an swollen lymph node under the arm from where it had the vaccine. And of course, we're always thinking, oh, well, hopefully that's a good immune response. There's lots of inflammation, but you can see why that might temporarily affect your blood count. And we know that CLL, even the white cell count, can be influenced from things like insect bites and so forth. So I wouldn't be surprised at short-term changes, but they will recover.
Great, thank you. Somebody has asked, because they have T-cell CLL, they're wondering if everything you've said is relevant to them or whether they would need to seek alternative sources of information on the topic.
Yeah, that's an interesting question. I've taught really exclusively and rather blindly about B-cell CLL, haven't I? T-cell CLL is much less common. I think everything still applies, you know, all the sort of things that we've said here are still appropriate for in pretty much all blood cancers, to be honest. You know, when you think about the blood cancers, I mean, CLL is one of the most immune suppressive, which is why we're particularly focused on this as a group. But I think the T-cell CLL would fall into the same sort of management approach.
Great, thank you. I was thinking throughout your presentation, Paul, that you mentioned that viral infection is usually more common in treated patients, but we've considered COVID to be a risk to all patients so far. Is that purely to do with lack of knowledge about this particular virus, or is there some sort of virology basis to that?
No, I think that slide, of course, that was the slide from a few years ago, and it was interesting to see it now. And as I said during the talk, thankfully, well, not thankfully, I mean, now we are dealing with a virus that's a real and present danger. It's just that the shingles, obviously, I would be surprised. It's unusual to see a patient on watch and wait, coming in with shingles, quite frankly, or cold sores and so forth. So those sort of viruses I tend to see later when treatment has been started. But obviously, SARS-CoV-2 is a risk throughout the disease course. Yeah.
Great, thank you. Someone's asked a question about they said monoclonal maintenance therapy. I assume they mean sort of intravenous immunoglobulins, and wondering if that yet will give them any protection from COVID. Obviously, those are antibodies that are collected from other healthy people and then delivered to a CLL patient. Is it likely that they already include a bit of COVID?
Yeah, interesting question. So the intravenous immunoglobulin treatment itself might include some COVID antibodies. Yeah, that's becoming interesting question. It's interesting from two ways. One is because it can carry through to the blood tests, and people can think, oh, you're protected, you've got some antibodies. So in the laboratory interpretation of the COVID response can be influenced by IVIG. And the second thing was, does it protect you? And I think the levels might be quite low, to be honest. It's my guess, just in that. But yeah, it's a live issue of debate. In fact, I was talking to Helen when we were talking about the CLL earlier today, Helen Parry, about whether we want to measure this, because we do have 40 people in our CLL-VR study who are on intravenous immunoglobulin, and we could see during their treatment whether their level of background immunoglobulin level increases against COVID. So we might address that. It's a very interesting question.
actually just clarified that they meant a monoclonal antibody in terms of actually treatment, which
Yeah.
is also a separate question that's probably equally of interest. They're wondering if that gives them protection, but I think I understood from your talk that monoclonal antibodies actually put you at more risk from infection. Have I interpreted that correctly?
No, I don't think so. Maybe I confused on that. So the monoclonal antibody treatment that you get when you come into hospital is two, manufactured antibodies that stick to the SARS virus and neutralize it. That's one company. Another company, AstraZeneca, has a very similar product, but they're aiming into the general population at home to protect people from SARS infection. And that's the PROVENT study that they're hoping to get approved in America and then I'm sure in Europe. So that's a monoclonal antibody that looks very hopeful, actually, that given to people who are vulnerable at home, it will improve their protection against serious infection. These are very clever antibodies because when we make antibodies, they drop by about half within about 3 or 4 weeks. They last quite a long time. But these antibodies that they've made are engineered so that the body doesn't destroy them, and they can last for months, 4 to 6 months. And so you can have an injection and have high levels of antibodies against COVID for many months. So yeah, there's a lot of excitement in the CLL community about access to these.
Perfect, thank you.
Charlotte, I think we've entered the third monoclonal antibody discussion. This person's on daratumumab for a maintenance therapy for their myeloma.
We're talking antibodies all over the place at the moment.
It's a different monoclonal, so I think the question is around, does that negatively impact on their COVID protection, or does it positively impact on their COVID protection?
Okay, thank you both. Yes, I understand. Yeah, there's loads of monoclonal antibodies used as therapy, aren't there? I mean, rituximab is one, and that does weaken your immune system. Daratumumab just being studied actually in myeloma. I saw some data on that yesterday, but that needs to come out. It does affect the immune system, but whether it's going to be good or bad, I honestly don't know yet, but it's being studied.
Thank you, Nick. I think we were 3 different scenarios there. All of them equally
three very
useful.
Interesting questions out of one.
Yeah, but at least we've got to the crux of that person's question. Thank you. Right, well, I think what we'll do is move on from COVID, because we're 2/3 of the way through the webinar. I have, for everybody watching on Zoom, I've posted a link to the webinar we did with Helen, and most of the other questions that we haven't covered, we definitely covered in that webinar. So please do go and have a watch of that afterwards, but I'm keen that we talk more generally about immune challenges while we have Gillian and Paul today. So I hope you'll forgive me for that, everybody. So moving on to some sort of more general immunity questions. Gillian, I wondered whether I could ask you, you mentioned some signs and symptoms of infection, but I just wondered if someone who's just been diagnosed versus someone sort of later treated on, do you give them all the same information on risk of infection and how to deal with it, or do you sort of tailor it a little bit more to depending on where they are in their pathway, do you think?
Yeah, no, I think it's important to cover all aspects of infection, whether they're newly diagnosed or whether they're further along the line. We offer like a red card alert system, which is a telephone number which is managed by nurses 24 hours a day. So if you have any signs of infection or any worries, you can ring that if it's in the evening or the weekends. So I think it's very important from day one really to reiterate the problems with infection, and we would do that at the same level whether they're along the line or at the start of treatment, really. Yeah. And
I think Nick raised a really interesting point earlier about balance and about, you know, protecting yourself from infection but not shutting yourself off from the world. Absolutely. Which people actually have done in recent months. Yeah. How do you encourage people to balance these things a little bit? Yeah. What advice would you share with the people listening?
Yeah, I mean, we want people to have a quality of life. You know, we don't want people to be stuck in their house and not going out. So we try and just give them sensible advice, you know, and say, try and live your life as much as you can, but just remain safe. You know, don't, obviously simple things, don't go out with people who are unwell or who have colds, don't go out in massive crowds, you know, but go out, exercise, get a hobby, you know, because I think the mental side of the disease is as important as the physical. And if you're frightened to go out and you're scared of getting an infection, you're not having any quality of life. And what we want to try and do is keep patients safe and free from infection, but also making sure that they meet with family and friends and go out and have some sort of social activities and some sort of life. I think that is equally as important.
Agree.
I don't know whether Nick agrees with that.
Yeah, I was about to say if Nick wants to add anything.
Yeah, I think I do. I think we've got to remain mindful. Obviously, COVID is COVID across the population, but it's important to consider we're coming into another time of the year now when we have to be mindful about other infections. We can maybe think back to that and just trying to balance things. You know, I have to admit, I struggle because I know I'm probably quite immune compromised. So I'm following COVID guidelines as best as I can at the moment. And I've actually found that negative to some degree because I've been isolating. It's made me a little bit complacent with other issues and not being maybe making sure I'm on the ball with regards to making sure I'm up to date with other vaccinations. And, you know, so from that point of view, I think it's important to reflect on your own weakness, or how often have you been getting infections? How often have they been serious? How often have they been negatively impacting on your life? And if you're in a mixed household, obviously you're having to deal with the challenges of COVID, you know, somebody going out into the community, either kids going to school. So you're dealing with that. But before COVID, or if you're not getting other infections, that should be able to give you some sort of an indication. How often are you reaching out for help with other issues? Are you getting opportune infections that are persisting? You know, that gives you some indication of your levels of how to balance the level of anxiety you have. It's really hard because I know for the early part of diagnosis, I was paranoid. As soon as I found out that I have an immune compromised, you know, potential, a disease that, you know, a condition that causes that, I went way off of the scale. And then I spent the next 10 years, you know, a few years sliding back onto it. So it became normal again. And now COVID's kind of sent me back the other way. But I think, listen to your body, listen to the frequency, you know, think how often you've been developing issues that have needed an intervention before COVID. Obviously, amongst all of that, we've got to manage COVID, and we've got to remain vigilant about that regardless of where our immunity is, because it's a nasty infection regardless. But, you know, I guess I live in a rural area, so, you know, I avoid going in closed areas. I don't get into cars and things with other people. I'm able to walk and exercise. And, you know, we've got a hybrid life now, haven't we? But yeah, I would draw everyone's attention that we're coming into winter. The flu jab's probably of equal importance to everybody. And I know that's something I'll throw out to Paul there. You know, we deal with it every year. Get your flu jab, even though in CLL we know you might not get the best response. And more importantly, work with your family, those under the same roof that I was just talking about, to make sure that they're taking on board all of those things that they need to admit to, that your family under the same roof are getting their flu jabs, because they are the ones that are going to protect you from flu if you don't get response to the vaccination. As usual, I answer a short question, then I'll answer. Apologies.
That's all right. No worries. I mean, Paul, did you want to come back on Nick's point there at all?
No, I think those are very eloquent views. Yeah, no problem.
Just wanted to check. I think what I was thinking throughout your presentation, Paul, was you mentioned some very specific illnesses. So we talked about hepatitis. Obviously, we've talked about COVID. We've talked about pneumonia and shingles. But I guess, what about things that we every day consider more common, like the common cold, for example? Should patients be worried about all illnesses, or are there very specific ones that are most concerning for CLL patients?
Yeah, I mean, I picked out a few there. I mean, just because we've got so many people now, certainly in my practice at least, on Cetrin because of BTKIs. And then we always screen for hepatitis, and so that was why I was covering those two. Common colds, I don't think that's been a particular problem, to be honest. No, it's ironic that many of these common colds are coronaviruses, of course. Who knows where that dreadful current virus will be in decades to come. But no, I don't think the cold is a problem that needs to, limit people, to be honest. Other infections, no, I don't think there's any other ones that I would pick out. Gillian, is there anything that patients talk to you about that you want to address? No.
Great, thank you. I think we've covered most of the other points here. I mean, Nick, have you got some, we've talked quite generally about people keeping them safe, but do you have sort of specific examples of things you do day to day that help keep you? So you talked about not traveling the same car as people, and have you got any specific tips at all? Just keen to give something more specific, I guess, to people listening.
Well, it's a difficult one, really, Charlotte, because our great leader Boris came up with hands, face, space, and we've kind of been living that way before as immune compromised people. Hygiene, avoidance, just being mindful, because we were already being mindful that we needed to wash your hands, and kitchen-wise, food safety. I don't know whether this was drummed in because of different stages in the disease. Early days, around, well, we're coming out of the gardening season, but around compost, things of that nature, just being mindful to wear your gloves. And I never put face masks on when I was around compost, but I used to make sure I watered it down before I handled it so that the spores weren't flying around. All those little aspects of just general personal hygiene and safety, just being a bit more mindful that, I suppose the way to look at it, why is it important that you look after all those little things? The last thing you want to do at the moment is to get poorly and have to go and see a doctor with so much COVID being in the community. So yeah. I would just be mindful about general health, keeping up to date with everything. It's a challenge for us at the moment. I don't know how we do that, Paul, with regards to dentistry, because dentistry was one big thing, obviously. We can't keep ourselves up to date in there.
Yeah.
Okay. It's a difficult one, Charlotte, to answer, because COVID has forced us to actually, if we weren't doing what would have been helpful before, we're doing it now,
I think everybody's talking about legacy of COVID and how we can learn from it. And I think we do want to improve vaccine and infection control of other infections now. It was quite embarrassing, really, when you try and introduce like a COVID vaccine into the CLL community and you look for the data on how does pneumovax work, how does influenza work in this community. It's very thin. People hadn't done enough work in this area, quite frankly. So we need to change that and improve things. And I did talk about Shingrix, and that might be a little interesting discussion to get going, because the guidelines just 1st of September, so we're only 6 weeks in. And as I'm understanding it is people between 70 and 80. Over 80, the risk seems to be, in the general population at least, go down. But it's delivered through the GP. There's quite a limited stock of this Shingrix vaccine, but patients with CLL, in my view, of course, I would say this should be at the front of that queue. But I'd be interested to know whether anybody on the line has, got the Shingrix, and whether that's something, Nick, that we should publicize for the community. Have you had much on that?
I think a few people have. What somebody's actually raised the question is, looking at the national curriculum for shingles vaccination, is Shingrix just for those over 70, or the immune compromised younger than that age, can they gain access? Because I guess from my own point of view, answering that question, you touched on all my lifestyle has changed as I've moved further along the pathway, because I have so much more prophylaxis. So I've probably got a little bit more relaxed and rely on the prophylaxis. So Cyclovir I'm on as a routine drug because I'm on the BTK and I've got history in that area. But yeah, without a doubt, I mean, there needs to be a little bit of clarity in that. And there's another question that comes off of the back of that somebody's raises. how frequent should we be having some of our regular, our periodic vaccines like the pneumococcus? Is there a time, or tetanus and things of that nature? It was part of the earlier question about safety, just keeping up to date with your vaccinations, and are there different frequencies? But with regards to Shingrix, we've how long have we, parrot fashion within the community, had to make sure we stand on the podium and make noises? You shouldn't have the shingles vaccination because, and we've had so many of our friends who've had post-hepatic neuralgia and the traumas that has caused for people.
Yeah. I
think it's massively important. I can name several peers that really had their lives ruined at later stages. So I would have, it is a big worry, isn't it?
Yeah.
But there isn't clarity. Somebody just raised the question earlier. Is it only for those over 70?
As I understand it, Nick, I was looking at the guidelines today. That's what it seems to be. The UK program is 70 to 80, and it's a live vaccine. But for patients who can't, like CLL patients, then they can get Shingrix in that space. But
it's the question, isn't it? Because if your immune capacity reduces with age and you're already immune compromised, and you've brought up there the secret, when we first all entered our journeys into CLL as patients, we soon learned that it was important that people knew about their vaccines earlier, vaccinations, especially those that are 5-year or 10-year, early on in their journey, to make sure you've got protection at a later stage. Surely that should be applied to shingles. Or is there a different mechanism? Because I don't know. You're the expert in that.
No, I think I was just talking about NHS approval, and I think that seems to be where it is. But yeah, certainly privately, I know a lot of people have got it earlier.
Well, Charlotte leads very much in leukemia care, and there'll be people on the line that are on our HTA work that represent the patient group. So it'd be interesting to know where that is in the system and where it's going.
So, like Paul said, it's based. The guidelines are 70 and over. Be interesting, Paul, to talk to you after the webinar if there is a need in the community below 70, whether we need to do some influence and work in that area. Absolutely.
Let's follow that up.
You raise a really important point.
I've noticed there's a comment on there to say that in the States it's advised for over 50s.
Yes.
So there must be some evidence base behind that, or at least you'd hope that we could tap into and look into further. Definitely. While we're on the topic of Shingrix, someone's asked if they've had a normal shingles vaccine, presumably before they had CLL 7 years ago, should they now get a booster, assuming they're within the age range? Of course. What's your thoughts on that, Paul?
I don't honestly know the data on that, but I wouldn't have thought there'd be a problem. I can't see 7 years later with a Cll vaccine there would be a problem. So I would imagine that's appropriate, but I don't know what data there is on that, quite frankly.
That's helpful. Thank you. And I think I just saw something on this topic just pop in. Oh, yes, this is what I was going to bring up. Gillian, I wonder whether this is something I could ask you about. I mean, a lot of queries and challenges that we get from CLL patients on the topic of vaccines is that knowledge among primary care professionals about the differences. And now we've got the Shingrix vaccine. I'm assuming it may become slightly more complicated. Do you have any advice for patients in having that conversation? Can you help, for example, as a clinical nurse specialist with those conversations in terms of sharing the latest information on what CLL patients need?
Yeah, of course. Yeah, and I think, the way the health service is going, there's going to be more integrated care between hospitals and primary care. So I think it's important that, that we keep each other supported and informed about what's happening with vaccines and things. Yeah, definitely.
Could I follow on from that with the question, because that's a broader question as well. When we look at the pneumococcus protocols that you touched on, Paul, how many GPs know about the frequency that CLL patients should receive their pneumococcus and the sequencing? Is there a mechanism or are there documents? This is something we've had to deal with quite often, is communicating with primary care that might not often have to look after the community, how we can ensure that as patients that we can appropriately inform primary care, or because we've got loads of these questions in the line here. People talk to their GPs and they don't know anything about it, and that even is even magnified at the moment, obviously with the third primary jab. Is there a mechanism there that we can employ?
I think we need to improve, don't we? I mean, there's few stories on the line about people going through. It's complex. You can imagine as a GP, they're dealing with all sorts of conditions. And then, knowing with a patient with CLL, what sort of pneumococcal is quite complex. So I think we need to perhaps improve that. Maybe from secondary care, we have a responsibility to get something together. So I think it needs to be improved is the answer. And the NHS will need to do better.
The guidelines you referred to from BSH, British Society of Haematology, they're publicly available, I believe. So if anybody does want to know where they can find them, we'd be more than happy at Leukemia Care to help you to dig those out. I'd say obviously respectfully, but don't be afraid to share these things with a GP. Like Paul, you say, Paul, GPs can't be expected to know everything. So if you need any help with that communication, we'd be more than happy to help you find the sources that Paul referred to there. As most of these things are written down, it's just knowing where they're written down as a patient can be challenging. Do you think that's fair, Nick?
I think that is. I think I used the phrase through my early journey in CLL, I kissed many frogs and learned to find GPs, and then the value of communicating and working together to build a relationship. And that's a two-way street, educating each other. And I found that most GPs prior to COVID, I don't know what the situation is now because you don't often get to see each other face to face at the moment, but that was an approach. And I believe the BSH guidelines have just been updated, but that was written into guidelines prior to this most recent update. So maybe we can also look at making sure we've got an inventory of documents that we can make available to patients when they get in touch with our advocacy service, and that would probably help Ella and the team and everybody else to provide that information.
Absolutely. We're sort of running out of time quite quickly. There's two more questions I thought were particularly interesting. One was whether patients can do anything to improve vaccine efficacy themselves. Paul, did you have any thoughts on that at all?
I don't really think you can. Unfortunately, nothing I can think of. I don't really have the evidence for it, but as just a member, as someone who's been vaccinated, I'm quite a believer in things like vitamin D and zinc. I think they support the immune system actually. There's some evidence for that, so I'm quite a believer in those sort of things. But I can't quote that there's a study in CLL that's going to improve things, but I quite like those. But otherwise, not really. Gillian, do you have anything to boost immunity, or you and patients, what do you discuss?
You're on mute, Gillian.
Sorry, it's been a long day. Nothing really, just a balanced, healthy diet, making sure you have, the things like kale and very good, effective, vegetables and meat, and just a nice balanced diet, really. I don't know if there's any, like as Paul said, I don't think there's anything that's been reported that particularly makes a vaccine more effective. I'm not aware of it. I don't.
Yeah. You haven't asked me about that gender effect. That's remarkable.
Is that down to fear of poor lifestyle choices?
Yeah, I wonder.
Yeah. I mean, from a patient point of view, I know I'm on immunoglobulins, but I do notice that I get run down if I don't follow certain lifestyle choices more easily. So exercise, a good mixed balanced diet without too much stodge, and sleep. And yeah, I'm an outdoors person. I make sure I never burn. I've got 2 enormous parasols in my garden, but vitamin D does make a big difference to me in general well-being. So I think that's all linked up. I'm sure many people on the call with us here will testify to that.
I think exercise is very important, Nick, that you've mentioned. And sometimes it's at a time when you feel very low and very fatigued and you don't want to exercise. So you have to force yourself to exercise, and then it helps the fatigue. So it's a bit of a vicious circle, really. So it's good to encourage everybody to exercise. even
Yeah,
when
I
they're
think
probably the last thing they feel like doing.
it's easy to get totally bogged down in CLL,
Yeah.
and probably COVID is causing us all to focus on that as a weakness. It's a holistic issue. It's our immune system is just a part of us, and we need to look after all of us. I think that's the way to look at it. And the more of you that is well, the more likely you are to fare well as well if you do become ill. I mean, you look at CLL patients, they look very healthy because we have a mantra of following a healthy lifestyle, so that if you go into treatment, when you do need treatment, you can better fare. Yeah. And I think that must apply to other areas as well. I try to practice what I preach, but I fall into bad habits, and winter is a really difficult time, So.
There's a question here from Sue, just talking about probiotics. And I mean, I did talk, didn't I? The challenge of infection, but also the bacteria in our gut help us to survive. They make a lot of vitamins for us. And there's a lot of interest now in having the right bacteria in your body. Whether we've got the right microbiome in CLL and whether we need to optimize that, there's no data on that yet, but it might be something for the future. But yeah, I would have thought probiotics is of interest, but I know of no evidence yet.
Yes, that was going to be my response, and my understanding of that area is very much interesting, but no conclusions as yet.
No.
I think antibiotics that we have to take quite often don't help us. No. Because they do leave you sometimes afterwards needing your gut to take some time to stabilize, and that in itself can run you down.
Yeah.
So we do have, I guess you'd learn to find what works out for you. But I think we've got to be mindful not to focus just on CLL. Life isn't just about CLL, and COVID has kind of brought that all back into focus again, and I see that myself. Because we're all missing out on lots of the activities that have been talking here. How are we going to get our families together for Christmas? When's it going to be safe to do that? How are we going to manage to do all of this? It's difficult, isn't it?
Yeah, absolutely. I wanted to end on an interesting question. I guess it's for you, Paul, to start with, but others may wish to comment. Someone's asked, well, I assume they've noticed this connection while talking to others with CLL, sorry. They asked why inflammatory conditions seem to affect people with CLL. Is that something you're aware of, Paul, or do you think that's perhaps a coincidence that this person's noticed?
Oh, yes. Well, I mean, there are a number of associations with CLL, of course. One is autoimmune complications, where it's ironic, isn't it? Because we're talking about weakened defenses against bacteria. And then on the other hand, the immune system seems to turn on ourselves a little bit, particularly against the blood system. Nick talked about hemolytic anemia, didn't he? About how our antibodies can attack the red cells. They can also attack the platelets, can't they? And even the red cell, even the bone marrow in rare cases. So it's interesting how the immune complications of CLL appear to affect the blood cells mainly, but they can affect other organs sometimes, very rarely, kidneys and so forth. Inflammatory conditions, rheumatoid, don't know of any particular association epidemiologically there, I must say, no.
It's anecdotal, but as a person removing potential inflammatory issues, quickly have definitely impacted positively on my life. And I know when I had inflammatory conditions, before there were interventions on them, they did make, I think the CLL compounded it all. And I don't know whether there's a connection. One thing that's really not been brought about, different infections. I mean, I used to get a lot of subcutaneous infections prior to my first treatment, and I was constantly having boils and things of that nature because I always had an immunity issue that was causing those. But one thing I now have, and I know a lot of us do, is reactions to insults, either infections from insect bites or overreactions to insect bites, those kind of things. Is that related to our immunity, or is that just related to us? I have to watch it very carefully if I get bitten by an insect, for example. It's an immunity issue. Quite often, I have to reach out for a bit of support because I end up with infection. But sometimes no infection, just an overreaction to a bite.
Yeah.
And that seems to have happened since CLL. And I think but there's not a lot of data and evidence collected in these areas.
Yeah.
It's about knowing yourself, isn't it? And knowing what you have to avoid. I keep the middle door downstairs in my room and my house closed all summer, so that there's a physical barrier. The dog doesn't like it sometimes, but there's a physical barrier so the biters can't get in the house. That's just one aspect of keeping safe from infection. I think the important thing is to learn over time to understand yourself, your own CLL, how it reacts in you, and how susceptible you are. It would be great, isn't it, at some point? I mean, you're the professor. Any chance in the future that there is going to be a way, with all of the work you're doing, that patients will be able to sort of measure their immune competence or get an idea of what their immune competence is at different stages in their journey?
Really interested in doing that, Nick. I was talking to someone earlier about measuring immune cell function. I mean, if you want your heart checked, you might have an X-ray to look at the size of it, but what you really want is an echo or something. See how well it's pumping, how well is it working? And yet, when we look at our immune system, Gillian and I just take a blood count, and then we see the patient in clinic and say, you've got, your neutrophil counts 1.3, your lymphocyte counts 1.2. That's just measuring them. We're not testing how well they're working. And that is a space that needs to be filled in medical research. And so we're very interested in that.
Well, I'm sure we'll all sign up to that one, as we've all signed up to your COVID studies. You can see how important it is to the community.
Yeah, great.
Yeah.
Thank you, Nick. That was a really interesting final question, actually, as someone in the chat box has agreed. So I think that brings us to the end of our conversation. Thank you all for chatting through everything today. We've covered quite a range of topics there. As I mentioned earlier, I posted the webinar link in the chat, which I think I might do one more time, to the previous webinar on COVID. So if any of your questions around the COVID vaccine, or COVID and CLL, or COVID in any other type of leukemia, Helen covered quite a few actually, go back and do have a look at that last webinar, because obviously the aim of today wasn't to cover everything related to COVID, whereas that was. So I hope that's answered your questions effectively. I've just got a few closing slides to remind you all of our services and upcoming events and things. Just wait for those to load fully.
Sorry, Charlotte, have you put the slides up, or did I?
You've done that.
Okay, there we are. They're up then. Hopefully
Perfect.
they'll click through for us.
Thank you. So just to remind you, we've got lots of other sources of information if you are looking for information on any other topic relating to leukemia. We've got a newsletter that went out today, actually. We have a quarterly magazine. We do podcasts. And also our website is probably the first port of call for all sorts of different types of information. Could I have the next slide, please, Nick? Thank you.
I'm seeing it. Are you seeing it?
Yes, I've got it. Don't worry. So we've got several books on CLL that we wanted to highlight, including Living Well with CLL, which I think touches on some of the issues we discussed today. So if you wanted to order that, just visit the link in the bottom corner there, and you'll be able to either download it, or we can send you a copy in the post on request. Could I have the next slide, please? We also offer a variety of support services, which you can access in a number of ways. We've got Helpline, we've got virtual support groups, and some of our support groups are actually going back in person, trialing that at the moment. So if you're interested in seeing people in person again, do have a look online to see if we've got any running in your area at present. And our online groups are actually particularly useful for this sort of topic, for living with challenges day to day. I think I'm sure you'd agree, Nick. Our Facebook groups, and we've also got a Health Unlocked forum as well.
And a very connected group with CLL support as well, that
Absolutely
is keeping CLL patients informed.
Could I have the next slide, please? One thing we wanted to highlight was our next webinar. We're very pleased to welcome Dr. Anne Johnson back. Some of you will know her from when we did in-person conferences pre-pandemic, but she also did our last fatigue webinar as well. She's fantastic. She's got some real helpful tips on managing your fatigue if it's something you do struggle with, regardless of what leukemia type you have, where you are in your journey. So please do come along to that webinar towards the end of the month. And I think that's, oh, here's some ways you can get in touch with us on social media if you use that, or on our website. And the last slide, please. I'll leave that up while I say thank you to both Paul and Gillian for coming along today and talking us through how you support patients through COVID and also many other immune challenges. Thank you to Nick for sharing his story as always. It's always helpful to hear your perspective on the topic. And I hope everybody has a lovely afternoon. See you again.
And thank you to
Thank
every patient
you.
for joining us. It's